Selby. Dr. Selby gained an undergraduate degree in biology from Missouri Southern State University and Baylor University, graduating in 2004. In 2008, Dr. Selby graduated from University of Missouri-Columbia School of Medicine with an MD. His residency training was performed at the Mayo Clinic in Rochester, Minnesota, where he achieved specialized training in both internal medicine and nephrology. Today, Dr. Selby works in the primary care department of Kansas City University of Medicine and Biosciences, is an assistant professor of primary care and subspecialty medicine, as well as being a fellow of American Society of Nephrology. His previous work positions include being a part of the nephrology and internal medicine department for the Mayo Clinic, as well as instructor of medicine for the Mayo Clinic in Rochester, Minnesota. Furthermore, he was a member of the Kansas City Kidney Consultants in Kansas City, Missouri, and worked in the nephrology and internal medicine department of Mercy Clinic in Joplin, Missouri. So now if you could all please silence your mics and use the hand raise function when necessary, that would be great. And take it away, Dr. Selby.
Before you do, Dr. Selby, I need to correct one thing, and it's my fault. I just learned that Dr. Selby did not graduate from undergraduate degree in biology. He said, "The heck with that! I'm going straight to medical school." So he's a rare bird altogether.
Yeah, you won't see that very often. But
take it away, Dr. Selby.
All right. Well, thank you. Let me share the screen 1 second here. All right. Can you guys see this?
Yes.
All right. I cannot see you, so you'll have to unmute and talk. I would like this to be interactive. This is kind of fun. What we're going to do is we're going to talk about glomerulonephritis. So this is an introduction to glomerulonephritis, and it's kind of a case-based approach. So we'll go through some clinical cases. And so there are learning objectives. I'm not going to spend a lot of time on this. You can look at this later on the video if you'd like. But before we get too far into it, I want to make sure we're all on the same page of specific definitions. So nephrotic syndrome. What is nephrotic syndrome? Nephrotic syndrome is a patient that has protein in the urine, and it's typically around 3 to 3.5 grams per day, or 3,000 to 3,500 milligrams per day. And they have low albumin in the blood, that's hypoalbuminemia, and they often have peripheral edema, and they'll have hyperlipidemia. Can you see my mouse when I move this?
Yes.
Good. And then they not only do they have hyperlipidemia, but they also have fat or lipids in their urine, so lipiduria, okay? So that's the definition of nephrotic syndrome. And I want to just make kind of a key point, which maybe only a nephrologist cares about, but if their serum albumin is normal in the setting of nephrotic range proteinuria, then the patient does not have true nephrotic syndrome. Instead, they have nephrotic range proteinuria. And why do I make that clarification? The reason it's important is, to a nephrologist, that helps me with the differential. So why does this patient have protein? Do they have what we call primary FSGS, which we'll talk about in a little bit, or something called secondary FSGS? So it kind of helps me clue in. So for nephrotic syndrome, you have to have low albumin. If you don't have low albumin, you don't have nephrotic syndrome. And then let's compare and contrast that to nephritic syndrome. So here you still have protein in the urine, but it's much less. It's less than the 3.5 grams per day. Often these patients present with somewhere around 1 or 2 grams per day. But by strict definition, they have hematuria and hypertension. And that's all you really need to make the diagnosis of nephrotic syndrome. You don't really need proteinuria. But when they do have it, it tends to be less. And often people who have nephritic syndrome will present with renal failure, typically acute kidney injury. And so the key point I want to make here is, when you look at the urinalysis and you look at the urine microscopy at the urine sediment, often as nephrologists, we say they have an active urinary sediment. And what is active urinary sediment? You'll hear that on the wards. That means they have hematuria, blood in the urine, or they have dysmorphic red cells. So it's blood in the urine, but the red cells are abnormal shaped. As they squeeze through the glomerulus, into the urinary space, they get distorted. So we call that a dysmorphic red cell. Or the red cells can bind to tan horsefall protein in the urine and form casts. So we call this a red blood cell cast. Or they can have white cells or white cell cast or something called granular cast. So key point here, they have active urinary sediment. On the contrary, nephrotic syndrome, we say they have bland urinary sediment, meaning we don't see a lot of these abnormalities in the urine. So those are kind of the basic definitions to get us started. And for nephrotic syndrome, I just wanted to go over a few complications just so we know how serious of a disease this is. Often these patients have edema, and we'll get into this in a second, but the question is why? Is it because they have a low serum albumin, so they have low oncotic pressure within the blood vessel, so they have a tendency to want to leak fluid from the blood vessel into the interstitial space? Or is it because they have more urinary retention of sodium, so they get an increase in their total body water and total body sodium? And we'll talk about that. They get hyperlipidemia, but why the heck do they get hyperlipidemia? Well, we don't know. That's the bottom line. But it's thought that it's from low oncotic pressure, and somehow this stimulates hepatic lipoprotein synthesis, so you get this hypercholesterolemia. They're often at risk for infection, and why would that be? Well, it's pretty simple. You lose all kinds of proteins in your urine. You're not just losing albumin, but you're losing other proteins, including your antibodies. So you can lose IgG and complement proteins, which will put you at risk for infection. And believe it or not, people with nephrotic syndrome are at risk of forming clots, thrombosis. And again, we don't understand why. They can be venous or arterial, but mostly venous. And the highest risk is when the serum albumin drops below 2, or some textbooks will tell you 2.5. But when the albumin in the blood gets that low, then we start getting concerned that the patient could develop a blood clot. And the question is, should we put them on anticoagulation, which is never an easy decision. And you can see there are different reasons. You have loss of antithrombotic factors, so you become more pro-thrombotic, or you have an increase in certain procoagulants. And this is a little table that just kind of gives you an idea clinically, what are the patients that are at highest risk of developing thrombosis? And for your boards, this is what you need to remember: membranous nephropathy. Membranous nephropathy is the glomerulonephritis subtype that is most associated with thrombosis. And we'll get into that more. Other complications, believe it or not, you get vitamin D deficiency because you have urinary loss of vitamin D binding protein. So often these patients present and you measure their vitamin D25 total level and it's undetectable. And so you end up having to give them high doses of vitamin C to try to replace, or vitamin D to replace it, usually 50,000 units weekly. And even with that, they tend not to recover until you can treat the protein and get it down to a more reasonable level. They're often anemic, and there's different reasons why, but they're losing transferrin and they're losing erythropoietin. Here's a figure trying to show you some of the alterations in the plasma protein and in the coagulation system that happens in nephrotic syndrome. We've talked about a few of them. I'm not going to go through it in great detail, but the point is you're losing all kinds of proteins, and it's causing all kinds of abnormalities to develop physiologically. So back to this concept of edema, why the heck do these patients develop edema? And we really don't know, but there's two theories. There's this underfill theory, this low intravascular oncotic pressure theory, and then there's this overfill theory that there's renal sodium retention. So the kidneys are just actively reabsorbing sodium and they're in water. And so that's kind of what you see here. The proteinuria will lead to low albumin, which could lead to low oncotic pressure, so you get swollen. Or the kidney is just primarily reabsorbing too much sodium and they're in water. And of the two theories, the overfill theory is probably the most correct one. And there's a lot more evidence to suggest that these days than the other ones. So what do we do? General management. Someone walks into your office, they have nephrotic syndrome. What are general things you can do? Well, obviously you want to treat the underlying cause, and there are, again, multiple different diseases that cause nephrotic syndrome, but each one has a specific treatment, although some have very limited treatment options. But in general, for their swelling, you want to restrict their sodium, and you want to put them on a diuretic. And the diuretic is typically a loop diuretic. In general, let me give you some advice. Do not use a thiazide diuretic to treat someone with edema. It has very minimal change in urine output. If you want to treat edema, you use a loop diuretic, and the one that we commonly use is furosemide, although you could use Bumex or other agents. For the protein in the urine, we want to reduce that because protein in the urine long-term will make the kidney function decline. So we try to lower their systemic blood pressure. We put them on an ACE inhibitor, ARB, which has been shown to reduce protein in the urine. And occasionally we'll put them on other antiproteinuric medications. Believe it or not, non-dihydropyridine calcium channel blockers, so like diltiazem, actually have some antiproteinuric effects. Aldosterone antagonists, so this would be spironolactone or apilrinone, or even direct renin inhibitors, although these drugs are still expensive and most patients can't afford them, so we don't use them. For the hyperlipidemia, we put them on a statin. For the thrombosis, we will occasionally put them on anticoagulation with either heparin or warfarin, but in general, I've never done it. A lot of nephrologists typically don't do it, but theoretically, you could consider it for certain patients. And for the infection, if they're getting lots of infections, you can just give them IVIG supplementation periodically, and I've done that. But I will just point out IVIG, some formulations of IVIG can actually cause acute kidney injury. So there's a little bit of a double-edged sword there. And then for the vitamin D deficiency, we supplement. As far as the differential diagnosis for nephrotic syndrome, it's huge. And here is just a few things, okay? And these things here are what I would call the most common. Diabetic nephropathy is probably the most common, and then you can have minimal change or FSGS, membranous, and some other diseases. There are other options or possibilities, but it's beyond what you would really need to know. It's more for the nephrologist. But I want to show you this slide because we talked about nephritic and nephrotic features or syndromes. And so this is a completely artificial determination by physicians to say that this patient has features that are more consistent with nephrotic syndrome and this patient has features that are more consistent with nephritic syndrome because it helps us with our differential diagnosis. And so you can see there is a multitude of different, I don't know if I have, oops. There's a multitude of different diseases here. Some of them are more likely to present with nephrotic features and some are more likely to present with nephritic features, but that doesn't mean that they can't be overlapped. So diabetic glomerulosclerosis or nephropathy is typically a nephrotic process, but it doesn't mean that it couldn't in some patients present with nephritic features. So you just have to be aware that this is all artificial and you have to take it with a little bit of a grain of salt when you're seeing these patients and trying to classify them and come up with a differential. How do you diagnose renal or glomerulonephritis? You have to do a renal biopsy. I mean, you can suspect it strongly based upon history, you know, and laboratory data, but you have to get a biopsy to confirm it and clarify the exact etiology. So let's spend a little bit of the time talking about how do you do a kidney biopsy and how do you know you get a good sample? Because, you know, anyone can go and take a sample from the kidney, but if it's not a certain caliber of sample, it is a waste of time. So one thing that you may or may not know, renal biopsies are extremely risky. And what do I mean by that? The big risk is bleeding. The kidneys, between both kidneys, you receive about 20% of your cardiac output or have about 20% of your blood volume. Think about that. So how do you do a biopsy? Well, you stick a needle in the tissue. So if you stick a needle in a bloody organ, what do you think is going to happen? It's going to bleed. And so we don't do renal biopsies lightly because, believe it or not, you can get such severe bleeding that the patient can lose their kidney completely or they can even bleed to death. So you have to be very careful who you select. In other words, the biopsy has to change your management. And for the most part, it will. So how do you know you have an adequate sample? Well, you get what we call 2 to 3 cores of tissue with a 16 or 18 gauge needle, so a relatively large needle. And you want to make sure that the most of this tissue that you get from the kidney is mostly cortex. And you want to have around 8 to 10 glomeruli because the question is, where is the pathology in the kidney? Is it in the glomeruli? Is it in the tubules? Is it in the interstitium? Is it in the blood vessels? You don't know. So you need to have a fair number of glomeruli on the biopsy to have an adequate sample. And in general, we like to try to make sure that these glomeruli are right at what we call the juxtamedullary border. So this is right between the border between the cortex and the medulla. These glomeruli are really important because this is where you see a lot of what we call FSGS. It'll start in this region before it'll start in other parts of the kidney. And you want to avoid any glomeruli that are right underneath the capsule of the kidney, because these often are sclerotic just from normal aging or from hypertension or for other non-specific reasons. And so they're not very helpful. So if you have a glomerulus underneath the capsule on your biopsy, you can see that, and it's completely sclerotic. It doesn't necessarily mean the patient has FSGS or something major going on. It could be normal. And you want to try to avoid getting too much medulla. Cortex is helpful, medulla for the most part is not. And you want to make sure you get at least 2 arteries. So when we do the biopsy, this is one of the more fascinating things about nephrology. We do a lot of processing. So we don't just do light microscopy like a lot of specialties. We do immunofluorescence. So we do staining for IgG antibodies or A or M or certain light chains or so on. But we also do electron microscopy, which is really cool. I don't know of very many other specialties that ever even get to electron microscopy. So we do a lot of processing after the biopsy. And this is how a biopsy is done. You have this little device. It has a long needle. And this device here, you can twist it, and there's a spring in here, and it will load the spring. And at the top is a button. You push the button, and a needle will be shot out of this aspect into the tissue and then gets returned back in. So that's where you get your core, and then the core comes back in to this part of the needle, and it protects it. A good nephrologist, I like to think I'm one of them, would look at their kidney biopsy right there in the procedure room. In other words, I don't just take the sample, put it on a slide, or put it in some tissue container and send it to the pathologist. I look under my own microscope under low power to make sure it was a good sample. Because if it wasn't, I can go ahead and do another quick sample right then and there. So this is what I want it to look like, the top figure. These little structures here, these are actually the glomeruli. You can see it on low power under the microscope. This kind of striated tissue, this is the medulla. If I saw this would tell me I had a bad sample and I should do it again. Because if I send that to the pathologist is going to call me and say it's non-diagnostic. And so I did a procedure and got no benefit. So I might as well go ahead and do it again. And so this is what, some of you have seen this. This is what the glomerulus looks like. You have mesangial cells that hold the vascular tuft together. You have podocytes, which form these filtration slits on the outside. And you also have the glomerular basement membrane. And of course, the endothelium is fenestrated. So this is kind of your barrier that only allows waste products, for the most part, to leak from the blood vessels into the urinary space and keeps the good stuff in, like protein and other substances. Well, this is what a normal light microscopy would look like. So this is a normal appearing glomerulus. Does anybody know? This is the interactive part, okay? Get ready. We're going to start getting interactive. What is this group of cells right here? Does anyone know? Somebody unmute and give me an answer. Okay, lots of participation. Well, I want you to participate. I'll give you a break on this one, but this is mesangial cells, okay? And I know that because it's in between the loops. This here is the nucleus. These are nuclei of mesangial cells. This is the nucleus of an endothelial cell, and then its cytoplasm goes all the way around. Right here, this is a podocyte. These are nuclei on the other side of the glomerular basement membrane in the urinary space. So you can identify the cells based upon the location of their nuclei. And then this substance here, this is the the Bowman's capsule. Here's what the electron microscopy would look like if you went back and we took this one little loop and we blew it up and looked under electron microscopy at just that one loop, this is what it would look like. We would see that you have your endothelial cell nucleus, and then it has its cytoplasm, which spans all the way around this structure, and it's fenestrated. And then you would have your glomerular basement membrane, and then on the outside you'd have these podocytes. So this is your filtration barrier. And if you lose podocytes, you have protein in the urine, okay? This is a close-up picture showing you the podocytes and the glomerular basement membrane, and then this is just the tubular, or the lumen of the glomerular artery. That's probably the top half of a red blood cell. So let's do some clinical cases. So I really do want you to participate on this. It's more fun. I know this stuff, so I like it if you guys participate. So anyone medical, please jump on, okay? So here's a case. You have a 75-year-old female, and they have new onset lower extremity edema for about a week. Their past medical history is substantial for osteoarthritis, osteopenia, Hodgkin's lymphoma, heart disease, hypertension, hyperlipidemia. They take ibuprofen, lisinopril, Lipitor, metoprolol, nothing all that unusual. On exam, they have anasarca. What does that mean? That means they look like the Stay Puft Marshmallow Man. They're very swollen, their entire body. On labs, you see their creatinine is elevated. Their creatinine is 1.9. 6 months ago, or say a month ago, the creatinine was 0.6. So maybe a month ago, they went in and saw their primary doc and they did labs and happened to check the kidney function and it was normal. You check the LDL is high at 190. Their albumin is a little low at 2.9. And on urinalysis, you see a predicted protein range of about 4,200 milligrams per day. But the rest of the urine looks relatively bland, no white cells, no red cells. On microscopy, you see this. Does anyone know what this is?
I see Mike Johnson is unmuted, so that means, Dr. J, you get to answer that question.
Now, from my perspective, Mike, it's a very small slide, but it's either crystals or foam cells, but I don't know for sure.
Yeah, so this is a little bit hard. It's actually fat. So this is what we call, it's hard to see, but if you can use your imagination, it kind of looks like a Maltese cross.
Oh, I see it.
So we call this a Maltese cross. This is free fat. And this down here is what we call an oval fat body. So this is just fat that's kind of multiple free fat droplets that have collected together. So what we see here.
What is that in foam cell?
Say that again.
Foam, F-O-A-M. I just remember that in connection with nephrotic, fatty or lipiduria.
Yeah, it's slightly different, but you're right. Foam cells are associated with nephrotics. It's slightly different, but the point here is that what we're seeing is what looks like nephrotic syndrome, and that the patient has nephrotic range proteinuria, hypoalbuminemia, hyperlipidemia, a bland urinary sediment, and then lipiduria. So the question is, what do you want to do next? Does anyone have an idea of what we should do next in this patient?
Consult.
Consult? Okay, well, let's say you're the nephrologist.
A biopsy?
There you go.
If you did a biopsy, you need to be very careful with that present anasarca. That would be a caution or red flag for me.
Yeah, you know, anasarca does make it hard, but we do our biopsies these days under image guidance. Predominantly, we do it under ultrasound. Some of the older institutions will still do CT-guided biopsies, but they're not as good. But with an ultrasound machine, you would feel pretty confident that you were in the right location and were getting what you wanted. In the past, I didn't tell this, but in the past, when we didn't do image-guided biopsies, you know, sometimes the pathologist would call you up and say that the loop of bowel is normal.
Yes. Yeah.
So, but with imaging, even with the anasarca, we typically can do it. But you're right, you just have to be cautious. So we would do a biopsy. And so this is what we would see. This is what we call an H&E stain, a very common stain. And so what do you guys see? Does this look normal or abnormal? You know, these are tubule cells, and this is a glomerulus. This is Bowman's capsule. Does anyone, what is it? Let's just start with this. Abnormal or normal?
Abnormal.
Well, it's not. It's actually normal. And the reason I'll tell you that is, and maybe this isn't fair, but you have to look at a few thousand biopsies before you get used to this. It's like everything in medicine. The more you do, the better. But if you look, you know, in the mesangial area, there's not an increase, what we call mesangial hypercellularity. There's not more cells there. There's not what we call endocapillary proliferation, meaning the capillary loops look open. And if you look, you can kind of get a sense of the basement membrane here. It looks normal, although H&E stain is not the stain that we predominantly look at to evaluate the basement membrane. What are these red things? Anyone? Those are red blood cells. Those are normal. They're in the capillary loop. You know, blood is flowing through, so that's normal. So this is actually a normal H&E stain. Let's look at a different stain. Let's look at a silver stain. Silver stain is important because it actually stains the basement membrane. And so here are the capillary loops, the basement membrane you can see. And what we're looking for, is there any abnormality? Is it thickened, or are there other abnormalities within it? I don't want to say what they are because we'll talk about other cases. But the question is, you know, you look at this, you go, well, okay, there's a capillary loop. Is it thickened? I don't know. How would I know? Well, we actually, believe it or not, we look at Bowman's capsule and its basement membrane and try to compare. Now, the problem on this, whoever did this stain, they stained it they put too much stain on the sample. So this is going to give you an artificial sense that this Bowman's capsule is thickened. In reality, these capillary loops look normal. They don't look thickened. I don't see any other abnormalities within them.
Probably silver staining. Probably this is Baki Agbas from Kansas City. Probably silver staining. This is a heavy staining. Then we may, or whomever is doing that staining, histologist or lab people, they can reduce the amount of the silver, so you can really have a fine details rather than the kind of overexposure of the silver stain.
Right, and so, you know, what happens is in the pathology departments, there are technicians that process the specimens, and they're the ones that do all the staining. It's not the pathologist. But you could use a different stain, and typically you'll do an H&E stain, and then you also do a periodic acid shift, PAS stain.
Yeah.
And that also looks at the basement membrane, but I didn't show you in this particular case, but I could have showed you a PAS as well. So here's the electron microscopy. And so this is a blown up picture. So here's a capillary loop, just one. Here's its nucleus. Its cytoplasm is going all around. And then here's a red cell. But what's wrong here? There's some arrows, right? There's the arrow sign. What's wrong?
Don't seem like you see a whole lot of foot processes or podocytes.
Yeah, this patient has what we call diffuse foot process effacement. So they have no podocytes here. And if I'm not going to show you, but let's say we did the immunofluorescence and we stained for IgG and IgA and for light chains and et cetera, and none of it comes back positive. What's the diagnosis in this case? I've given you the diagnosis. Your board exams are going to give you this and show you all of this, and they expect you to know the answer right now. You may not know why they have this particular disease, but you should know the disease. So you had a normal appearing light microscopy, negative immunofluorescence, and diffuse foot process effacement. Does anyone know? This is minimal change disease. This is what a normal electron microscopy would look like. So here are these foot process, these slit foot process, okay, in the slit area. So this is minimal change. Minimal change disease is a very interesting disease. It has kind of two peak incidences. You'll see it in children. On the boards, if they present a patient who has nephrotic syndrome and they're a young child, we presume that that child has minimal change disease since it's the most common glomerulonephritis seen in children. And in fact, we don't even do a kidney biopsy usually. We just treat them, and typically we give them steroids because minimal change disease is very sensitive to steroids and typically responds well. But believe it or not, there's a second peak incidence in older adults. But the interesting thing is when the older adult presents with minimal change disease, they typically have pretty severe renal failure from ATM. And so on pathology, you would see a normal light microscopy, a negative immunofluorescence, and this diffuse foot process effacement, 75%, 80% or more. And I'm not going to get into this too much, but I'm just going to tell you that, there are really two types of minimal change disease. There's what we call primary minimal change disease and a secondary minimal change disease. Primary, we do not understand why people develop primary minimal change disease. We have no idea. We have a theory that there is a circulating permeability factor, which may be an antibody, it may be a protein, it may be a cytokine, we don't know, but it circulates in the blood and eventually causes podocyte death and apoptosis, and they fall off. But then there can be what we call secondary FSGS, and so this can be seen in certain things. So certain drugs like NSAIDs, and I'll just point out this patient was on ibuprofen, and I put that in there on purpose, so you might consider they could have a secondary minimal change, or Hodgkin's lymphoma is a common association with minimal change, and this patient had a history of it, so I won't get into the rest, but that's minimal change. Now, when it comes to treatment, I already told you, these patients, for the most part, are pretty sensitive to steroids. So you typically give them high-dose steroids, and if that doesn't work, you can use other immunosuppressive therapy. Now, you would only do that if you thought the patient had a primary minimal change. You would not do it if you thought they had a secondary. And here's the key points for your boards. In children, if a child presents with nephrotic syndrome, it's minimal change. And the thing they want you to know about in adults is minimal change disease is associated with NSAIDs and Hodgkin's lymphoma or other lymphoproliferative disorders. And it's typically steroid sensitive, meaning they get better quickly with it.
Is there a temporal association with the Hodgkin's? For example, might this suggest a recurrence, or is it, what's that temporal association?
Yeah, so if a patient had minimal change disease and I was concerned that it could be secondary, like in this patient that had a history of Hodgkin's lymphoma, I would be very suspicious that it's a recurrence. Having Hodgkin's lymphoma and then having it treated would not be a risk factor, okay? But if you had a recurrence of your Hodgkin's lymphoma or had another lymphoproliferative disorder, that would be concerning, okay?
Thank you.
I have a question. Is this, isn't this originally called NIL?
Yeah, this used to be called NIL disease, yep, or lipoid nephrosis, because you would look, nephrosis just meaning abnormal kidney function, and lipoid because there was fat in the urine. So it has lots of other names, but the name that we use nowadays is minimal change. But yes, NIL disease is an older term for it. Yep. NIL meaning nil, like nothing was found on biopsy. That's why we call it minimal change, because there's minimal changes on the biopsy other than the electron microscopy.
Thank you.
All right, let's do another case. So in this case, we have a 26-year-old African-American male. He's presenting with new onset hypertension and worsening edema for the last month. He has minimal past medical history. He has allergies, asthma. He takes Claritin, Advair inhaler for his asthma. On exam, he's hypertensive. He has anasarca, so he's swollen. His creatinine is right at the border of normal, abnormal. African Americans typically have higher muscle mass, and they tend to have a higher creatinine, so you always have to be careful when you interpret creatinine in that ethnicity. When we look here, we see the albumin is low. Low end of normal is around 2.5. His is, 3.5. His is 2.2. On urinalysis, there's a predicted 15 grams of protein per day, or 15,000 milligrams per day. So that's getting up there. The urine sediment is bland, no white cells, no red cells. He's got fatty cast. And then, you know, the person who saw this patient was a pretty astute clinician, and they went ahead and ordered, they already have a general sense. I mean, if you were taking a board exam, the boards are painting a picture for you. And what you should be thinking is that this patient probably has nephrotic syndrome. And the fact that the patient is an African-American male, we'll get into it, but it puts them at high risk with a certain condition. And so there's different causes, that the reasons why patients could develop that condition, but they did certain serology. So they did HIV, which was negative. They checked the complement C3 and C4 levels, which were normal. And they checked an ANA, which is really, you know, plus minus a good way of screening for autoimmune disease. It's not really recommended for the most part. So what do you want to do next? Biopsy, right? For time's sake, I knew that's what you wanted to say. So you do a biopsy. So here you go. Here is 2 light microscopies, okay? And so here, this is an H&E stain. Actually, this looks more like a PAS stain, I'm sorry. And so you see this lesion here, and then you see this lesion here in the glomerulus. Does anyone know what that is? This is an adhesion. So the glomerulus has an adhesion here to the Bowman's capsule, which it shouldn't. So an adhesion in the setting of this kind of endocapillary proliferation here is pathognomonic for sclerosis. So this patient has sclerosis, but sclerosis in and of itself is not specific. You can have sclerosis in almost any disease. Here's an electron microscopy. So here are several capillary loops. And so what do you see? You know, here are some red blood cells. That's what that is. But there are no podocytes. See? Everyone agree? No podocytes? And then...
We haven't looked at 1,000 of these.
Okay, well, there's no podocytes. This patient has diffuse foot process effacement, and they have sclerosis. But then, more importantly, when you do immunofluorescence, you notice in the areas of the glomeruli that are sclerotic, which just means fibrosis scarred, that there is staining for IgM and there's staining for C3. So I've given you the diagnosis already. Does anyone know what it is?
Lupus?
No, good to think about lupus. It's not lupus. Lupus does have a positive immunofluorescence. Lupus is what we call a full house on immunofluorescence, meaning when you stain for IgG, IgA, IgM, C1q, C3, C4, all of your antibodies that you're staining for are positive. So we call that a full house. So lupus is easy. When everything's positive, it's lupus. But this is just C3 and IgM.
Dr.
So,
Selby?
yeah.
I was curious about the negative staining, how it looks like, because the staining is very strong in the peripheral, but it's a little, you know, the weak on the center. I don't know, just a negative control, how it looks like, you know, for the comparison.
So that's a good question. So, you know, this figure down here in the right lower quadrant is a little bit of an exaggeration. Typically, when you look at immunofluorescence under the microscope, there is low-level staining among the entire tissue. So it looks kind of green, the entire tissue, the glomerulus, the tubules, everything looks green. But when what we do is we actually categorize this by how bright it appears as +1 or 2 or 3. And so the higher, the more intense it is, the higher the plus rating it would get. So this is more typical. You would see this entire glomerulus kind of look lit up, but this part is far more intense. So that's how you know that this is abnormal, and this is probably just normal background staining. This here, I don't know if they've changed the contrast or whatever in this picture to try to just emphasize the sclerotic reasons, but in general, it would have a little bit more of a greenish appearance. Does that help?
Mike, I noticed student Dr. Matthew McAuliffe had his mic unmuted for a second. Doctor.
Oh, I did. I just guessed like an IgM nephropathy because I couldn't think of another name for anything, but
So you know what? IgM nephropathy is a very rare thing. It does exist, although some people kind of question it, but it probably does exist, but it's not. This is what we call focal segmental glomerular sclerosis, or FSGS. And you know, you may remember this from your pathology time, but this is a terrible diagnosis. This is a diagnosis you don't want.
Mike?
It's hard because it's hard to treat.
Mike Johnson has a question.
Yeah.
Mike, my question was, I don't remember, but doesn't this amount of protein in the urine appear to be out of proportion to the man's plasma level of albumin?
No, not necessarily. I mean, it can get lower. I mean, you can see albumins into the low ones, but this isn't all that atypical necessarily.
I thought
and, he's a younger patient and probably has a reasonable diet. As you know, albumin is produced in the liver, so patients with liver failure will have low albumin, or patients that have poor dietary protein intake can have low albumin. He probably has a reasonable diet and otherwise healthy, so it's not necessarily out of proportion, but it can get much lower.
His albumin level was normal or lower normal.
Yeah, 3.5 to 5.5 is normal. His was in the low 2s, but that's not uncommon, even with that degree. And I'll tell you, you know, I've seen people with 25,000 milligrams of protein in the urine, so that's really, really on the high end. So, So let me just explain this concept of this focal segmental glomerular sclerosis. What does it actually mean? Because people don't, I think, understand it, and it's pretty simple. So if you look, if these are glomeruli, all these different circles are glomeruli, look at the top two. So if all the glomeruli are affected, meaning they're red means it's abnormal, green would be normal. If all the glomeruli on your biopsy sample all look sclerotic, we call that diffuse involvement. If it's only a few, so when I look at my core biopsy, these glomeruli and these glomeruli look normal, but these don't, it's focal. So that's where the word focal comes from. And then segmental comes from each glomerulus. Is the entire glomerulus involved, or is it just a little section? And if it's just a little section, we call that segmental versus global. So this is focal segmental glomerulosclerosis. So it's not that hard, I don't think, to understand, but I don't think it's that clear in textbooks. So this is probably the most common cause of nephrotic syndrome in adults. It's somewhere between 25 to 40% of all cases, and it's very common in African Americans. African Americans have a risk of developing APOL1 gene mutation. And if you develop this, this is puts you at risk for podocyte loss. Some authors have said that we shouldn't call patients with APOL1 gene mutations focal segmental glomerulosclerosis. We should just call it its separate own disease, APOL1 associated nephropathy. And that's because they tend to have more global sclerosis than focal, meaning the entire glomerulus is involved. But anyhow, that's somewhat of a side point. The other thing I want to really emphasize here is FSGS is a histological diagnosis only. So if I do a biopsy and I get a report back from the pathologist that the patient has FSGS, that doesn't necessarily mean I'm done. I mean, the patient could have diabetic nephropathy and have FSGS lesions, or they could have other pathology, you know, hypertensive nephropathy and have some FSGS lesions. So it's very non-specific.
Mike?
Yeah.
Bucky has his hand raised.
Go ahead.
Hi, this is Bucky from Kansas City. I'm just curious about the percent of the APOL1 gene mutations in African Americans, whether any difference between the females and the males. What's the distribution? Thank you.
You know, I don't know the answer to that, but I have not in all of my training come across anything that commented that there was a difference between men and women. But I'm not going to tell you that there isn't. I don't absolutely know the answer to that, but in general, I've been under the impression there's not a difference.
Mike?
Yeah.
Student Dr. Mohansky has a question.
Go ahead.
Dr. Selby, so I was wondering with the APOL1 gene, is that a protein that contributes to the podocyte, and is that what's causing the sclerosis, or is the sclerosis like an immunological thing, or what's causing that?
You know, it's been too long. I can't tell you exactly what APOL1 does anymore, because when you get to my level of as a clinician, you don't get down to that nitty gritty. There are certain, like you can have Padosin and other specific podocyte mutations that are hereditary that can lead to a secondary FSGS. But as far as APOL1, I can't tell you specifically what it does. It's just, it's a known gene mutation. As far as pathology, you'll see this focal segmental glomerulosclerosis, and in the sclerotic areas, the IgM and C3, and then diffuse foot process effacement. Yeah.
Okay, thank you.
Go ahead.
Mike, I can comment on that just real briefly. The APOL1, there's a notion that it was selected in the African population because it is effective at preventing sleeping sickness, or supposedly that's what happens. And so you could understand why that might be selected out there over time.
Okay, well, that's good to know. I've not heard that. Real quick, I just want to spend 2 seconds on this. So you can also have either primary or secondary FSGS, very similar to minimal change disease. And again, if it's primary, we think it's an autoimmune disease. So again, we think there's a circulating permeability factor or cytokine. We don't know what it is. In fact, we think that minimal change disease and FSGS is actually a spectrum of the same disease. You know, some people manifest as minimal change and some manifest as FSGS. A few years ago, there was a nephrologist who thought he determined that what this, quote, circulating permeability factor was. It was what he called soluble urokinase receptor, or SUPAR. And so this got published, and man, it made everyone in the nephrology world get super excited, because for the last 60 years, we had no idea what was going on. And now all of a sudden we identified this substance, and then hopefully that would have led to treatment. But what we ultimately found out was, if you measure SUPAR levels in patients with all kinds of different glomerulonephritis, so minimal change disease, FSGS, lupus nephritis, etc., they all have elevated SUPAR levels. So it wasn't SUPAR. So we still don't know. But we got excited for a little while. Go ahead.
Just for the audience, Dr. Rogers and myself put something in the chat regarding APOL1 for further reading, just so you know.
Oh, perfect. Thanks, guys. And then you can have secondary FSGS, and this is going to be the thing you see a lot. So this can be a patient that has diabetic kidney disease, or they can have CAS nephropathy, multiple myeloma injury to the kidney, whatever. And you'll see that there's scarring in the kidney. The other thing you can see it in is if I removed one of your kidneys and left you with just one, that one kidney has to have adaptive changes to try to filter your blood. So it has to do twice the work with half the amount of mass. So you get these adaptive structural changes. So you can see it in people that have nephrectomies, or you can even see it in obesity. I'll tell you, I saw a patient at Mayo Clinic who probably weighed 600 pounds. He was from the Middle East. He was a royalty person from the Middle East. And he was so large that he developed a secondary adaptive structural change in the kidney and developed this secondary FSGS. So, and he went into renal failure and had to be on dialysis from it. Obviously, it took a long time. It didn't happen overnight. And the only thing on treatment I want to point out here, just so we can get through other cases, is that this is very treatment resistant. So unlike FSGS or minimal change, where I give someone a steroid and they get better, FSGS typically doesn't get better with anything we do for the most part. And so sometimes if we biopsy someone and we don't see any abnormalities, and we say, oh, maybe it's minimal change, we don't see any sclerotic lesions, when we give them steroids and they don't get better, well, we say, well, either they have really resistant minimal change disease or they have FSGS and we just didn't sample it. So we call it unsampled FSGS. And the only associations I want you to know is African Americans and FSGS go together, and HIV. You'll see this on your board exams where they'll say, here's a patient with HIV, and there's different subtypes of HIV nephropathy, but these patients develop what we call a collapsing subtype of FSGS. And so these are the big associations you would want to know for your boards. And Dr. Staudinger, is it okay if I go through all of them? It's going to be a little bit longer. Is that okay, or people can stay on if they want?
Well, you and I have a CPR2 LO meeting at 2:00, just so you know.
All right, well, let me go through some more. So here, let's just do a few more. So here's a 63-year-old or 65-year-old male who presents with a non-productive cough for 3 months, new onset right flank pain for 2 days. You can see he's got hypertension, hyperlipidemia, diabetes, heart disease, stroke. He's a smoker for 60 years. You can see the meds. I think I lost a slide here, but anyhow, you end up doing a chest x-ray on this patient, and what do you see? You see this large abnormal mass in the right lower lobe. And then you do a CT scan of his abdomen, and so here's the kidney, the right and left kidney. And what you notice is there's an abnormality in this structure here. This is the renal vein. This patient has a renal vein thrombosis. So this is a pretty concerning. This is why he has that flank pain. That's why they did the CT scan. He has this renal vein thrombosis. And you do labs, and you see his creatinine is high. He's got a low albumin. He's got lots of protein in his urine. He's got a few red cells. He's got some fat. And then you do sort of an autoimmune quick evaluation, and it all came back normal. And on biopsy, you see this. So you can see there's a little we call mesangial hypercellularity, but the basement membrane, this is a PAS stain, is a little bit thickened compared to the Bowman's capsule. So he has a thickened basement membrane. And if you do silver staining and get a little bit closer, you see these little spikes. And sometimes what you'll see is, depending on how this, the tissue is processed, you won't see the spikes, but you'll see little holes, what we call pinholes, or vacuolization in the glomerular basement membrane where there's no staining. And when you do immunofluorescence, you'll see that there's IgG staining diffusely throughout the glomerulus. And when you get a little bit closer, this is the key buzzword, it's granular. It's not linear, it's granular appearance of IgG staining in the loops of the glomerulus. And when you get on immunofluorescence, you can see here's a loop, here's a blood cell, but here's a loop, and there are these immuno or electron dense deposits. And what side is the deposit on? It's not on the subendothelial side, it's on the subepithelial side, so there's a differential. In this case, the patient has membranous nephropathy. So the things that I want to point out real quick on membranous nephropathy is that it is very commonly associated with malignancy and with renal vein thrombosis. On your board exams, if they give you a patient that has glomerulonephritis with a renal vein thrombosis, it's membranous nephropathy until proven otherwise. And this can be what we call primary or secondary. Primary is autoimmune. Secondary can be related to other things. We'll skip this for time's sake. The nice thing about this particular disease is you may not have to treat them initially. You can sometimes sit on your hands and just wait, and about a third of them will get better on their own. Another third will just have kind of stable protein in the urine and have a little bit of progression, and another third will move on to ESRD. The main way we treat this is with steroids and with alkylating agents, although nowadays there's a new study that just came out called the Mentor trial from the Mayo Clinic, which suggests that rituximab is the preferred agent. In fact, before I transitioned to KCU, one of my last patients I saw had a primary membranous nephropathy, gave them rituximab, and they responded very, very well, which is an anti-CD20 monoclonal antibody.
Dennis Wolf has his hand raised.
You didn't talk about the PLA receptor.
Yeah, I skipped that. Yes, but you know what? That's a good point. We can talk about it. So, for the primary membranous nephropathy, we did not know the cause of it for years, but in the last 10 years, we've made a lot of progress, and we believe that these patients have antibodies directed against the M-type phospholipase A2 receptor. So we call it the PLA2 receptor antibodies. And that's about 70% of the patients. Now, there is a subset that have this thrombospondin type antibody, about 10%, but PLA2. So now what we do is we measure and see if a patient has PLA2R receptor antibodies. And if they do, we measure a baseline, we give them rituximab, and then we keep measuring it. And what you'll see, if it works, is their if the rituximab gets rid of their B cells and plasma cells, you'll see a reduction in that PLA2 antibody. And that's what I saw in that patient that I treated. But yes, this is a new thing. This is an important new thing, but I kind of skipped it for time. But you're right, Dr.
Mike.
Yes, sir.
Since it's your meeting, we can be late.
Yeah, I tell you what, I think this is the last case.
Okay.
And if it's not, we'll make this the last case. But this is a fun case. So let's do this one. This is a 78-year-old male. They present with generalized fatigue, edema, 50-pound weight loss. So, you know, this is a big concerning feature when a patient comes in and tells you, particularly if it was only over 3 months. You know, they got COPD, they've got Crohn's disease, diabetes, you know, AFib, MUGUS. What is MUGUS? Monoclonal gammopathy of undetermined significance. So it means we can detect the monoclonal protein in their blood, but we don't think it's doing anything for the most part. Although, remind me in a second, and I'll tell you what the current term for this is. Medications, nothing all that surprising. You can see he's a little hypotensive. His heart rate's a little bit low, which that's kind of atypical, right? Usually patients with nephrotic syndrome are hypertensive. So that's a little atypical. And why is he a little bradycardic? You can see he has pancytopenia. His white count is low. His hemoglobin is low. His platelet count is low. His kidney function is not good. He's got 3.8 grams of protein in his urine, some red cells, some fat, and he's got hyperlipidemia. And then you see this. Now, this isn't a complete exaggeration. I did this just for emphasis, but does anyone know what this is called here? You also can see this in people with basilar skull fractures.
Isn't it just raccoon sign?
Yeah, raccoon eyes. Yeah, so basilar skull fractures. This patient doesn't have a basilar skull fracture, but you can have raccoon eyes in that, or you can see a purpura over the mastoids. But this guy has, let me tell you, this guy didn't fall and hit his head. Let's say this guy was, went to the restroom to defecate, and you know, he went in looking normal, and then an hour after defecating, he came out and he looked like this. And then what's wrong with this? He's got macroglossia. His tongue is enlarged. So this is a hint of what's going on. Well, I don't want to give it away yet. So what else do you want to do? Does anyone know? For time's sake, you went ahead and did a monoclonal study because he already has a history of monoclonal disease, and everything I've shown you says he has a nephrotic syndrome, and nephrotic syndrome can be caused by monoclonal diseases, so you want to check. So he's got diabetes, but his diabetes is relatively well controlled. He's got this monoclonal lambda seen on SPEP and UPEP. And then if you do something called serum-free light chains, you can see he has a lot of lambda light chains, which you'd expect. So his ratio is low. And if we do staining, this is kind of very interesting. So on silver and PS staining, this doesn't look normal. Look, there's all this salmon-colored material that has been deposited in this glomerulus, but it's not picking up the silver stain. It's not black. So it's silver negative. And then over here, you see this PS stain, but you see the salmon-colored material, but it's not picking up this PS color, this darker purple. And so it's PS negative. And on silver, if you blow it up, you see, it's kind of hard to see, but you see there's some eyelashes. They're like big spikes. So it's not membranous nephropathy, but they're big spikes. We call them eyelashes. And then you do immunofluorescence, and you see that the glomeruli are staining with lambda. So there's lots of light chain lambda present in the glomerulus. So that's probably what that salmon-colored deposition was. And then you do a Congo Red. Could have done a what is it? Dioflavin. Would have done the same thing, but this is apple green biopharyngeans, polarized light. So this is what? Matt McAuliffe.
Amyloidosis?
This guy has amyloidosis, and that's what this was. So the amyloid, these light chains get deposited in everything, the kidney, the blood vessels, and in the blood vessels, it gets deposited in the tongue, so your tongue gets large. But in the blood vessels, any blood vessels, but it gets deposited in the capillaries, and when you increase your intra-abdominal pressure, it can actually cause these blood vessels to rupture, and that's what happens, and that's why you get these raccoon eyes. So he has amyloidosis, and if you do an electron microscopy, you can see that there's this weird electron-dense material along the glomerular basement membrane with podocyte effacement. And if you blow it up, you see that these fibrils are kind of haphazardly arranged. We call it random. If you measure them, they'd be around 7 to 12 nanometers, but they're just kind of randomly arranged fibrils. So this patient had a primary AL amyloidosis, but I'll tell you that there are all kinds of amyloidosis. All amyloidosis results in the same disease. It just depends on what the precursor protein is. In an AL or primary, it's a light chain or an antibody, but it could be other things. It could be transthyretin, etc. And this protein will be deposited in various tissues, and then local enzymes will break it down and ultimately form these beta-pleated sheets. So here's like a list of different options that can cause amyloidosis. You get a secondary AA amyloidosis that's often seen in people that have kind of chronic inflammatory disease. So that's AL amyloidosis. The reason his heart rate was low and his blood pressure was low is he probably had cardiac involvement. So his electrical conduction system had been affected, and he probably had a restrictive cardiomyopathy. So anyhow, that's the end of it. These are the quick summary. You know, nephrotic syndrome, you have to have a low albumin, and comparing that to what we call nephrotic range proteinuria. So that's a key point. Glomerulonephritis, you know, can present with either nephritic or nephrotic, but there's significant overlap. And again, there's multiple etiologies for nephrotic syndrome, multiple complications, and the treatment really depends on the disease, but there is a standard thing that we do for everything. So statins, blood pressure control, ACE inhibitor, ARB, blah, blah, blah. And FSGS is not an actual diagnosis, it's just a histological finding, so be careful with that. Any quick questions?
I have one.
Yeah.
Would it be okay if I retrieved these slides from you and I posted them in the MKRC Canvas site? Is that okay?
Absolutely, absolutely. And this would be good for those who, you know, are taking boards. There's those key point summaries are good associations that you'll get questions on.
Awesome. So are there any questions from student doctors? If not, what we should do now is show your faces and show your appreciation for our speakers. So thank you very much. Yeah. Student doctor, did I see student Dr. Plumley had a question? Maybe. Student Dr. Plumley, did you find your microphone? You might look in the oven. It could be there. Right, Yumin? All right. Thank you again.
All right.
Take care, everybody. And don't forget, this is a weekly thing. There's a seminar tomorrow, journal club tomorrow. And next week, we'll, at the same time, same place, will be Dr. McNabb. Shelley, would you like to say a word about tomorrow's seminar?
Sure. We have sorry, can you hear me?
Yeah.
We have student Dr. Una Kem, who will be presenting on some medication and treatments for COVID-19. So please join us tomorrow at 1 o'clock for that.
Okay.